Johanne Silvain, Gilles Montalescot, Mike Gibson coming to you live from ESC 2024, and we're talking about the ABYSS trial, talking about discontinuation of beta blockers post-MI. Talk to us a little bit about why you did it, what you did, and what you found.
Yes, it's a great subject. Like we know that we all have beta blocker. Sorry, let's start again. It's a very important subject topic for clinicians. We have a lot of patients with beta blockers and the long-term beta blockers after myocardial infarctions, and we know the data are dating few decades ago, and now we have treatment of angina with complete revascularization. We have less heart failure. We have concern about the quality of life with beta blockers. So it was an idea that several people have, because there's several ongoing trials about the subject, that probably we could stop beta blockers without any problem in terms of safety and even improve the quality of life of the patient.
And so how many patients did you randomize, and what was the design of the study?
We randomized 3,700 patients, and we tested a non-inferiority hypothesis. We wanted to show that primarily there was no safety concern about stopping long-term beta blocker treatment. And then we also wanted to show as a main secondary endpoint an improvement in the quality of life of the patient.
And were these both STEMI and non-STEMI patients, and was it blinded?
It was not blinded. It was an open label randomized trial that was performed in 49 French centers. It's an academic funded trial led by the Action Group. And we had mostly STEMI patients, 2/3 of STEMI patients, probably because they were kept longer on beta blocker therapy, and 1/3 of non-STEMI patients.
And how long after the MI did you wait before the beta blockers were discontinued?
The inclusion criteria, they were very easy. You need to have a past MI, had at least 6 months of beta blocker therapy. When we look at the result, it was probably longer time, because the median time between the last MI and the randomization was around 3 years. So they were long-term, chronically treated beta blocker patients.
And what did you find?
So we wanted to show the non-inferiority. Unfortunately, we did not show the non-inferiority. There was a higher rate of event, around 23%, 23.8% in the interruption group. The primary endpoint was death, MI, stroke, and rehospitalization for cardiovascular reason. Every event was adjudicated blindly. And there was a 21% event in the continuation group. So we could not show the non-inferiority. And there's a signal toward an increase of events when we look at the hospitalization, especially the hospitalization for recurrent angina or coronary reason.
So Gilles, how do we put all this together? What do we take away from the study?
You know, it's an important question. It's a pragmatic academic trial, and the message is important. We have a safety signal when we stop beta blockers, even 3 years after an acute MI. And clearly, there may be reasons behind this signal. We saw the blood pressure going up. We saw the heart rate going up. And we saw many patients with angina coming back to the hospital, needing coronary angiography, needing PCI, and having more frequently rehospitalization. So it's kind of surprise, because we believed it would be safe and comfortable to stop beta blockers for these patients. And actually, it's not something we are going to recommend. And the second surprise of this trial is that there was absolutely no change in the quality of life. We may believe that beta blockers have an impact on the quality of life of these patients. Actually, we found nothing.
Well, this is why we do randomized trials. We often get surprised. You got a little surprised both on the safety and quality of life side, and that's why we do the studies. Well, congratulations to you two on a well-conducted study. Thanks for joining us today, and thanks to all of you for joining us here live from ESC 2024.